program என்ன program
اوريدي 13 واحد داخل. دين اوفيس
apa? Kapan ya?
Hello, good morning. Good morning, our friends.
Good morning.
والله العظيم
Morning.
والله العظيم لو تتكلمي حرف عمري ما باكل منك شيء. ترى الاسبوع الماضي عزمت. والله بزعل منك. خلاص اسكتي، عيب عليك، عيب والله. ما كان حاجة.
The خلود, your mic is on. We'll be waiting a little bit for other members to join. I can see that we do have now, I think, 20 participants joining.
Yeah, we have 20.
What is the time now in China?
In Shanghai, we are 3 p.m. in the afternoon.
Oh, 3
So you
p.m.
are in the morning.
in the morning. I see. Now
Yeah,
it is
11.
11 a.m. in the morning over here.
Yeah. So
And how's the weather over there?
yeah, it's sunny. It's a very good
Sunny.
weather in Shanghai. Yeah. Mm.
Okay, so it's 11 a.m. Good morning, everyone, or good afternoon or good evening. So depending on when you are joining from. So it is my pleasure to welcome you to this first joint seminar between the College of Nursing at Sultan Qaboos University here in Oman and the School of Nursing at Fudan University in China. So we are very happy to meet today with our esteemed colleagues from Fudan University School of Nursing. We are excited to embark on this collaborative journey where we will exchange research ideas, learn from each other, and explore this potential for future joint projects. So the seminar provides a valuable opportunity for both institutions to share insights that advance our mutual goal in research and in education. Now, before we begin, I just would like to remind everyone that this session is being recorded. Also, it is being live streamed on YouTube. So I shared with you the YouTube live streaming if you would like to share it with anyone. Now, we will have a full program today featuring 8 presentations, 4 from Sultan Qaboos University and 4 from Fudan University. Each speaker will have 10 minutes to present, followed by 5 minutes Q&A session. So I encourage everyone to use the chat function for any questions during the presentation, which we will address them during the Q&A session. Now, just some housekeeping notes. Please keep your microphones muted at all time and use the chat to communicate. Of course, unless you are presenting, each and every one of us has our hosts, so you can share your own PowerPoints and you can unmute yourself. And so without further ado, let's begin with the welcome remarks from our Dean of the College of Nursing at SQU, Dr. Huda Al-Na'mani, followed by a welcome remarks from the Dean of the School of Nursing at Fudan University, Prof. Hu Yan. So let's start first with Dr. Huda.
Good morning, everyone. I hope my voice is clear to everyone.
Yeah, very clear.
Okay. So good morning. It's my privilege actually and my pleasure to welcome all of you who are joining this joint research workshop today. And a warmest greeting to our collaborators or partners from Fudan University at China, as well as a special warm welcome to Dr. Prof. Yuhan. So I'm very happy to meet you. I missed last time the meeting because of other commitments, but I'm very happy to see you and the colleagues from Fudan University. At this occasion, also, I would like to thank all attendees, all participants, and a special thank to all organizers from Sultan Qaboos University, Dr. Michael and his team, as well as from Fudan University. I'm very happy to see this opportunity of joint collaboration. And I believe this is an opportunity for all of us to exchange not only knowledge, but I think we will go beyond also the culture, and it's going to be extended as research collaboration and also education collaboration. I'm very happy to see this the first collaboration existing between the two institutions. And I hope really that will enrich the future collaboration, as this is not only a knowledge, as I said before, but it's also an intellectual collaboration and exchange of knowledge. I would like to thank all participants and speakers from both universities. I think this also will be the beginning of future co-fund or research collaboration. And I think we are to that goal as well. So that's what I can say. And I hope all the best, inshallah, for this workshop. And it's going to be a joint workshop, and it will be for the future as well in different occasions. Thank you so much. I will be monitoring all of the workshop, inshallah, and speakers behind the screen. And I welcome our friends from Fudan University again. And a thank to all of you. Thank you so much.
Thank you very much, Dean, for your insightful words. We appreciate your constant support. Now, I will leave the floor to Prof. Huyan from Fudan University.
Okay. Good morning, our friends from Oman, from College of Nursing at Sultan Qaboos University in Oman. So it's the first time for us to meet colleagues from Oman, from nursing college from Oman. So it's all great pleasure. We firstly, earlier this year, we have the opportunity to meet the president coming from your university and develop the bridge, the link between two nursing schools. From the introduction of your president, we know that nursing school is quite have a very good reputation in international and also in your country. So we are very pleased to have this chance to have introduce our faculty members, our researchers, and our staff and our PhD students today, to have this chance to listen to your presentation and share our research with your research. Match with what you have provide for the full presentation. We match a similar area of studies in our school. So let me have the privilege to introduce our faculty member today, who will present their research during this seminar. The first, our professor from our school is Professor Yuan Changrong. Please just say hello, Professor Yuan Changrong. Yeah.
Hi, everyone. Nice to meet you all.
Yeah, Professor Yuan is our one of the leader of our research group who focus on cancer care and the patient report outcome. And we have another presentation from Professor Chen Yu, Associate Professor Chen Yu. Please say hello to everyone, Professor Chen Yu.
Hello, everyone.
Yeah, Professor Chen Yu's area of study is on chronic disease management, and she focused a lot on the patient with on the heart disease. So she will present what her study on this area. And the third presentation coming from our young faculty member, Annie Wang.
Hello, everyone.
Our young faculty member, Annie, she's focused a lot on chronic aged care in our school. So, and me, I'm also one of the presenter today. I will share some of my studies on evidence-based practice in maternal and child healthcare. So it's all great pleasure. We hope we could develop from this seminar, online seminar, we could develop further collaboration in terms of research and student exchange. As we don't have, in addition to your president's visit last time, we have some visitors, but not in nursing, in other area, like in pharmacology and clinic medicine, but no nursing student exchange. So we hope that we could have further student exchange in nursing, and of course, some research collaboration in terms of nursing. So that's my welcome, and also some of the introduction about us. Okay, thank you.
Thank you very much, Prof. Huyan, for your wonderful presentation. And of course, we are open for any kind of collaboration with your esteemed university, School of Nursing at Fudan University. We can explore student exchange and other collaboration for sure. So from my end, before we start, also let me present our esteemed presenters. We have with us Dr. Sulaiman Sabi'i. He's an associate professor and also a dean of the postgraduate studies. And Dr. Sulaiman, he is a member of the Fundamental and Administration Department, and he will be presenting about patient-reported outcomes, practice environment, leadership, and collaboration. Then we have with us also another associate professor, Dr. Judy Arulapan. Dr. Judy, she is our simulation unit head, and she is also a very active researcher in everything regarding simulation. She will be talking about interprofessional simulation, the insight and outcomes. Then we have also a speaker, Dr. Zainab Al-Azri. Dr. Zainab is an assistant professor. She is member of the maternal and child health department, and she will be talking about adverse childhood experience, impact on adult health. And finally, we have Ms. Frincy Francis. Ms. Frincy, she is very much interested in studying our students, and her topic is about time management, procrastination, performance, and anxiety among nursing students. So these are the four speakers. Let us welcome Prof. Huyan from Fudan University to discuss the first topic, which is the evidence-based child healthcare.
Okay, thank you for the introduction, and I'm very pleased to share my area of study in evidence-based child healthcare. Let me just share my screen. Is that clear? My voice and the screen, is that okay?
The voice is clear and the screen is clear as well.
Okay, so my great pleasure for the next 15 minutes, I will share some of my study in evidence-based maternal and child healthcare. Here is the greeting, some greeting from Shanghai. I hope that you have chance to visit the beautiful city of Shanghai, the river, and also the modern city and the ancient city of Shanghai. And in nursing school, we have like 100 undergraduate students recruit every year, and we have 70 postgraduate students recruit every year. So not a very big school, but we are one of the top nursing schools in mainland China. Okay, my area of study is in cancer care and evidence-based practice. So let me just share some of my study in evidence-based practice. We are one of the collaborated research center of Joanna Bridge Institute in Australia. Joanna Bridge Institute is one of the biggest evidence-based practice research center globally. And in Joanna Bridge, which in short we call JBI, there are 70 collaborated centers and some affiliated centers. We are one of the collaborating center of excellence. We follow the model of evidence-based healthcare proposed by Professor Ellen Pearson from Joanna Bridge Institute in the year 2005. And then the model was updated in the year 2016, which have the goal of evidence-based practice focus on global health, and also the key elements of evidence-based practice focus on scientific evidence, the context of evidence implementation, the clinic expertise of health professionals in that context, and also patient preference, the patient's needs in the context. So that's the key elements of evidence-based practice. Based on that philosophy, the process of evidence-based practice, especially in nursing, focus on four phases of evidence cycle. Start from evidence generation, from research. If there is no research, coming from expertise. If there is no expertise, we're coming from discourse. That's evidence generation, but the evidence should be critical appraised based on their quality and the feasibility and appropriateness to the context. So the second step for evidence-based practice focus on evidence synthesis, which is systematic review, evidence summary, or develop some evidence-based guideline. And then the evidence should be transferred or transmissioned to the bedside, first line, a point of care in active dissemination or system integration into the health information system, and to provide a lot of training of what is evidence and how to adapt that evidence. Yeah, can you still hear me? Yes?
Yes, we can.
Yeah. Okay. And the final step is evidence implementation, which is the goal, the optimus goals to have context analysis, facilitation, or barrel assessment of the context, and to making change and evaluate the outcome in terms of the process and the patient outcome. So it's very, I think, a very logic and very fluid models of evidence-based practice. Based on that, we can understand there are 4 attributes to evidence-based practice hierarchy. The evidence should have some defined hierarchies, and evidence should be coming from a different type of research we call pluralism of evidence, and also the context-related attribute and dynamic attribute of evidence. So here is a hierarchy, the pyramid of evidence pyramid. We follow that pyramid to develop evidence from primary study and to synthesize evidence, to conduct a systematic review, and also to summarize this evidence into clinic practice guideline. And the final optimized practice of evidence is put evidence into the decision support system in point of care. So that's the hierarchy. But the evidence coming from different type of primary research. So we have the level of evidence grading system. In addition to grade system, which is developed by WHO, we also have Joanna Bridge, their level of evidence we call pre-ranking of evidence coming from primary study and the systematic review. So they have the 5 level of rigourous of evidence. And also we also consider when apply evidence into practice, we consider the feasibility and appropriateness and meaningfulness to patient and to clinic bedside nurse, and also, of course, the effectiveness to the patient outcome. So we call JBI frame structures for evidence implementation. So all that, and also the updating of evidence should be conducted every like 3 years to 4 years. But actually, the updating of evidence is coming every year. So a lot of guidelines are updated every year, like the NCCN guideline. So there is evidence ecosystem. It is a cycle of produce evidence, synthesis evidence, creating guidelines to HTA, health technology assessment, and also dissemination evidence to policymaker, and also implementate and evaluate the outcome. And the engine or the mechanism of putting all these cycle in a stable way or sustainable way is digital structured data and platform and tools and the common methodology of evidence-based medicine. And we should develop a culture for sharing all this evidence and using some universal standard to critically appraise the quality of evidence, and then coordinate and support the implementation of the evidence. So that's the model. So in addition to that model, we also focus a lot on the implementation of evidence into practice. There is evidence implementation model developed by our center based on more than 80 project of evidence implementation. The evidence implementation is not an easy job. It is quite a complex intervention. Start from evidence, and the key is multidisciplinary collaboration, and the strategy to put evidence into practice is project management. And then leadership is very essential during the whole process of preparing and initiating implementation, evaluation, and facilitation. And the goal is to put continuing quality improvement as the final goal of evidence implementation. And all the process of evidence implementation, we use implementation science as a background, as a methodology background of evidence implementation. So all that are the preparation for us in maternal and child healthcare in evidence-based practice. We actually, in our center, we develop some clinic practice guidelines in terms of like breastfeeding in NICU, in the NICU for breastfeeding. It is not easy job in NICU to provide breastfeeding, but we develop the guideline of how to facilitate breastfeeding in NICU. And another one, this one is a clinic practice guideline for us development enteral nutrition for infant with congenital heart disease. This group of child is very hard in maintaining their nutrition, maintaining their weight. So for nurse, we developed the clinic practice guideline to provide enteral nutrition, especially the technique and also the process and the disciplinary collaboration of provides effectiveness feeding for this infant with congenital heart disease. So that's one of the guidelines we developed. And we provide a lot of recommendation abstracted from WHO and also from our guideline development, like the earlier and uninterrupted skin-to-skin contact between mother and infant should be facilitated and encouraged as soon as possible when they give birth. So that is the guideline we developed and the evidence is the recommendation of evidence is strongly moderate quality evidence, and we put that recommend that evidence into the NICU, the NICU, to provide breastfeeding and skin-to-skin context for a mother and also the infant. For them, for some of the neonatal, they are in incubator, but still can have the chance to have skin-to-skin contact with their mother, with their parents. So that's just some example of the guideline development and the guideline implementation in the new NICU place. And another one is for the NICU, we also develop some guideline and also adapt some guideline from AHA, like neonatal resuscitation, cardiopulmonary resuscitation guidelines, especially for the oxygen use of later preterm newborn. We control the providing of 100% oxygen. We provide only 21% or to 30% oxygen in the resuscitation in NICU, because the guideline is also provide a level of evidence, strong level of evidence of providing not full percentage of oxygen to prevent the other damage to the eye and also to the damage to lung. So that is also one of the way we keep update the evidence and put it into our practice. Here is one of the video we are in the neonatal ward on evidence-informed point of care, intravenous infusion of fat emulsion. So let's have a look at the process. Here is just when the clinic nurse come to assess patients children who were going to have intravenous infusion of fat emulsion. Because that for evidence, we scan the bar here, QR bar here, and there is recommendation from their electronic PDA that CVC or PICC, the channel is recommended for IV of fat emulsion. So that is evidence. We put that evidence into their PDA. So every nurse, when they scan, they were reminding the evidence that CVC or PICC should be used, not other channels for the infusion of fat emulsion. So that's put the evidence just into the point of care, and also let's just continuing have a look other evidence. One is just one of the evidence put it into the PDA. One is the selection of CVC or PICC, and also when we have the fat emulsion, there is another evidence just put into PDA that because it is fat emulsion, the evidence recommended that 1.2 mu, meaning the equipment, the filter should be provided, not the normal filter. So that's the evidence, put it into PDA. So every nurse can have a look at, can see it and remind them that you should have the correct decision makings for selection of IV channel and also the filter. So here is just some of the example in a children's hospital. And also we have pen assessment of all these different type of scales and put it into our the information system for different age patients, use different like FLACC for the year 2 months to 7 years. and for phases scale for 3 to 8 months. So all this evidence, we just put it into the information system. So every nurse, when they use the PDA in assessment pen, they can select the correct tools for pen assessment. And also for the kangaroo care, it's also the good evidence to provide kangaroo care to reduce pen access intervention. So we also use that evidence and put it into our clinic practice. So that's just some of the example. Like for prevention, the evidence provided, like pampering and hampering and pampering 4 scales is a special pen assessment and scales for children. So we put that hampering and dumping scales, just hang it in on the bed, and so everybody, especially the children and their parents, and also health professionals, will see this children is in higher risk of fall, and pay special attention to them. And this is not frequent; it is very acute. So everybody, especially children, will like this type of figure. So it is just some example where the evidence in our journey is in the first version to second version of evidence and quality of care, and to the third version of evidence in advanced practice nursing development. And also now we are in the third version of generation of evidence-based decision making. So we would very much like to have chance to have collaboration with our colleagues in different country, especially our colleagues in Oman, and we could have some more collaboration in this area. Thank you so much. Thank you. If there are any questions, I would very much like to share with, discuss with you.
Thank you very much, Prof. Huyan, for this insightful presentation about evidence-based guidelines production in maternal and child healthcare. So if anyone has a question, I invite you to write it down so we can ask Prof for her answers. So if anybody has a question. Prof. Huyan, I'm interested in the continuing quality improvement for your guidelines. You discussed about it. Like how often does this happen?
This happens every day. It's happened every day, because when we have the procedure, it's happened every day for all the project. Like if we focus on fall prevention or IV safety of IV injection, so we just put all this evidence into the procedure.
Okay, and did the artificial intelligence, the AI, helped you in any way to make things easier and faster?
Not now. Now we are using some information system, but AI is introduced, but not fully used in clinic.
Okay, and do you think
we hope we could have more?
I believe it's coming, right?
Yes, it is coming.
Okay.
Everywhere, AI. Yeah.
Great. Thank you very much, Prof. Huya, for your presentation. Now I will leave the floor for Dr. Zainab Al-Azri from SQU to present about adverse childhood experiences impact on adult health. Dr. Zainab, you are muted.
Can you hear me now?
Yes, we can, and we can see your presentation.
Thank you so much for this opportunity to present my work and my research. I'm Dr. Zainab Al-Azri. I'm going to present about adverse childhood experience and its impact on health outcome among Omani population. So this is just a brief about our College of Nursing, and I'm going to proceed with the presentation. My research about adverse childhood experience, and when we define it, it is referred to the potentially traumatic events that occurring as a child that can lead to long-term health problems. Imagine that you are a child, and every night your father or your father coming back to home
and he is like completely drunk. Or maybe like your mother is having mental issues, depression, and every day you are in stress. Or other situation where the child every day or in between he gets sexually abused, physically abused, emotionally abused, or some of his parents die, or some of his parents getting divorced or incarcerated. All these potential traumatic events can lead to long-term impact on health. And if you think about it, here just examples of the adverse childhood experience. It include abuse, neglect, and other, like growing up in a household where there is alcohol, there is some domestic violence, there is community violence. Different. You might see in a different research many other types of adverse childhood experience. Why do we care about adverse childhood experience? You can imagine that every day the child gets exposed to this adverse childhood, it will lead to stress. As I said before, every night that child waiting for his dad who will come completely drunk and he maybe hit them, beat them, all of that stress going to accumulate and lead to chronic toxic stress. And that will lead to prolonged high level of cortisol. And you know, with the stress, we get that high level of cortisol. Definitely that high level of cortisol will lead to abnormal or altered brain development. Children normally still their brain is developing and anything can affect or impact the normal development. And cortisol definitely one of those components that will lead to abnormal development in the brain. And once the child has abnormal brain development, you can imagine that they will have abnormal stress response. They will have abnormal decision making. They will having behavioral problems. They will having mental issues, depression, and anxiety. And definitely with that high cortisol, they will have a lot of organ damage, and eventually it will lead to chronic disease, including diabetes, hypertension, cancer, and many other chronic diseases. So worldwide, a lot of research have been done to investigate the association between adverse childhood experience and the outcome during adulthood. And it's well established that if you have adverse childhood, your odds ratio or likelihood to get these diseases like chronic diseases, high risk behaviors, and mental issue, it will be higher. So the question might ask, like, why I'm doing this research if it's well established worldwide? So if you think about it, Oman is a little bit different in its culture. Like in Arab culture, we have our unique culture, and this uniqueness make actually, you can think of it as the positive and negative side. It can influence the association between adverse childhood and the outcome during adulthood. If we think from positive side, we have a lot of social support system, our community having a lot of social support. So if your parent dies, still there is an uncle looking after you. Or somebody, if your father in a prison, still somebody will take care of you because we are a community-based culture. This might mitigate some of the effect between adverse childhood experience and long-term impact. However, on the other side, we're having a lot of lack of resources, and we want to talk about lack of resources in terms of mental resources, mental support, official supports. Imagine, like, for example, if the child, his father died, maybe there is not a lot of resources, like mental resources to support that child because he lost his parent or something like this. And also another side is social stigma associated with the ACI. When we talk about social stigma, if the child gets, for example, child abuse, sexual abuse, something, they will not, like parent trying sometimes to hide this one. It's not easy for them just to go and say, oh, child get abused, let me get him some help or support. Sometimes they will hide that one, just avoiding the social stigma. So thinking of lack of resource and social stigma, you can think of it like this association between ACs and long-term could actually getting bigger and the odds ratio getting higher. So that's the reason why I would like to see this association or the magnitude of the association in Oman. So as I said, my objective or my aim for this study was to identify the prevalence of ACEs and also to investigate the association with the mental health disorders, including depression and anxiety and suicidal ideation. The second one about with the high-risk behavior, including smoking, alcohol consumptions, and chronic disease, diabetes, hypertension, liver disease, and cardiac and obesity as well. So we use, I'm not going through details here, it's convenience sampling, and we use valid or reliable tools used worldwide. WHO developed the questionnaire. Basically, in the questionnaire, we target Omani adult who are older than 18. We ask them about their history when they were small, like when they were children. Did they ever getting all this type of adverse childhood? And also we ask them about their current situation, health situation, and their current behavior. Like, do they smoke? Do they using alcohol? Do they having any suicidal ideation, depression, and all of that? So the results, to just make it simple and easy to understand, we find that almost 38 of the sample, they having had undergone 4 or more ACEs. That means it is common for people to getting 4 or more ACEs. And also, as I said, I'm not going to read everything, but just to understand it, that any participant or any person who undergone 3 ACEs, he or she at a higher risk, very higher risk to get some of the mental health problems, including depression and anxiety and suicidal ideation. Also, they are at a higher risk for behavioral problem, including smoking, alcohol consumptions, and sexual behavior, sexually behavior. And also they are at a higher risk for cardiac problems, chronic respiratory problem, and also they will be at very high risk, 6.1 odds ratio for obesity. However, we didn't find significant relationship with the diabetes, hypertension, and liver disease. What does this say? That we are not different than other countries. Although our culture differ, we still, the impact of ACEs on people is still the same and similar to the one that worldwide. So regardless of the culture, the impact is still there, and we have to work in our country more harder and make more initiatives in order to mitigate this impact. So what we need, basically our recommendation from this research, that we want to protect children. So any initiation that could prevent some of the ACEs, we will try to do it. And also we are trying to think of screening children for ACEs. Actually, I would like to clarify that currently in Oman, you will hear more that child abuse and neglect. Very rarely or almost you will never see somebody saying adverse childhood experience. In this research, we find that it is not only child abuse and neglect. Sometimes just as simple, you having a father who died, a mother with the depression, that can cause harm to the child. And we need to address those children and support them before they develop long-term impact or long-term effects. So screening children and using tools, sometimes some tools were already used in different countries to identify those children and support them before, and be proactive in supporting them before developing the effects. Also, this research called for the need to improve access to mental health. This is we are impressed need for improving the access to mental health, and also trauma-informed care. This is a very well-known practice outside, but not in Oman. In a minute, I will explain it further what we mean by trauma-informed care. And definitely, we need further studies to dig deep on identifying which type of ACE is more harmful than other, so we can make more efforts to target that specific ACE. Okay, so regarding trauma-informed care, imagine that when you here in the practitioner, some of the doctors, nurses, when they see person or a patient who is obese, they will think he is obese because he is eating too much, drinking too much. He is not aware of his health. He doesn't want to lose weight. Less likely they're thinking, well, this maybe has some issues had happened for him since he was a child. So trauma-informed care, let the practitioner and nurses, doctors think of like those people with the obese, smoking, alcohol, or different diabetes. They might have something have happened to them since they are child. And the only things they need maybe some mental support, some health, some emotional support to take them out of that dark space they lived in throughout their lives to a place where they're having more insightful, more space where they can clearly think about their self and their health. You can see from the picture, this is the aim of trauma, that we need to take those patients from this dark space to a better place where they can think of themselves. And we cannot do it unless we identify that history they have been through and take them with the support of mental health and everything to take them out so they can take care of themselves much better. And one is just put one examples of like how trauma-informed care should change the practice. So the practitioner or the nurse should ask, normally what they will ask, what is wrong with you? With the trauma-informed care, the question should be changed to be, what have happened to you? You can see the difference. That will lead to more respect. So the patient will be able to open up, talk more, feel more respected, and he will be able to share his history much better than the first question. So that's all for my presentation. I hope you get like the main message of it, and welcome for any question.
Thank you. Thank you very much, Dr. Zainab, for your insightful presentation. Please feel free to drop your questions to Dr. Zainab in the chat. Meanwhile, while waiting for your questions, Dr. Zainab, so you found that there is a kind of connection between the ACE, right? The adverse childhood experiences with health outcomes, right?
Yes.
And you discussed something very interesting about the Omani culture, which has a very strong social support.
Yes.
So how do you think we can leverage this strong social support to improve an early intervention, or how can we help prevent or kind of treat this adverse childhood experience so we don't really reach the problems that you discussed about?
Yes, so as I said before, like this study is just more of initially we did it to actually understand whether actually we are like the magnitude of the association. So now I think the next step, it would be how to enhance all these like protective factors and implement them enhancing. And I think the first, like the step between would be the screening for children. So and unless we identify those children, then we will be able to enhance the social protection. I will give you example here in Oman. We try now to work on that, how to enhance the foster care using extended family instead of like using like a stranger families. And that because social system will help protect the child, and they found that less effects will appear in the child, for example, who lost his parent for any reason, which is considered to be adverse childhood experience. So I think could be one, and also the awareness among people how this ACEs can actually lead. So they will support children once they will be aware of the negative impact of ACEs when they happen. I think they will be able to support children more.
That's very nice, Dr. Zainab. Thank you very much for your presentation. Now let me welcome Prof. Yuan Shangrong from Fudan University School of Nursing to discuss about the patient-reported outcomes in China research and practice. So I will leave the floor to you. Thank you, Dr. Shangrong. Prof.
Thank you. Thank you. Good afternoon. Thank you very much for having me here today to share our research and the practice related to patient-reported outcome. I'm the head of the Patient-Reported Outcome National Center, China, which means I'm the official representative of the patient-reported outcome measurement informatic system. I take this role since 2019. To be honest, we just returned back from Cologne, Germany, to attend the Patient-Reported Outcome International Conference this year. And together with my students. So today, I'd love to invite my PhD student. She's the secretary of the PNC China to introduce our situation of this center. So Xu Qian, my student, will introduce the center.
Hello, everyone. My name is Xu Qianzong, and I'm very honored to give you the presentation of how we have during the past few years. So first, I'm gonna give can you hear me? First, I'm gonna give a brief introduction of our PNC China. So Professor Yuan was officially authorized by PHO. Oh, can you hear me now?
Now we can hear you, but we lost the presentation.
Okay, I have just shared the screen. So in 2018, we are officially authorized by PHO as the representative in China. So we held a celebrating a ceremony during the 2019. So we invited the PHO board member, Professor Dr. Sella, to come to China to attend the ceremony. And to construct the PNC China, we have an organization structure, and we invite 3 external clinical experts to help us to conduct our researchers. They are from different hospitals affiliated to Fudan University. They conduct us. They gave us help with the pediatric, physical, mental, and social health, and also the adult social and physical mental health. So within the PNC Center, we have 3 PhD for helping us to do the administration work. And so within and without the construction, we have these 4 missions: to advance the science of health outcomes assessment, to disseminate standardized and validated health outcomes questionnaires, and to foster development of new patient-reported health outcomes of diverse populations, and finally to educate the scientific and clinical communities on the science of patient-reported outcomes. So in the next part, I'm gonna tell you something about some progress we have done in the recent years. So first, we construct a PNC China network. It can be divided into 2 parts. For the first part, we build a translation team. After discussion and reporting to the organization, we have decided 23 translation teams to help us to translate the PROMISE tool into Chinese, and they included 5 children units and 18 adults units. So after we finish the translation part, we construct a validation and application team. Up to now, we have more than 80 clinical hospitals to join into this team to conduct clinical validation and application. So also, we have cultivated several researchers within our research group. So we have 10 graduated students, and for now, we have 4 postdoc and 9 doctors, and 10 master students. And our research direction can be divided into 2 parts. First is the measurement, validation, application of PROMISE tools. Second is that how we can PROMISE tools into smart, intelligent mobile softwares to help us collect data. So based on this, we built a nursing laboratory, and we have those wearable glasses and some softwares to help us do the usability test. And the second, we built some official website and official WeChat account to help us promote the concept of promise and PHO. And this is our official website. On this website, you can apply for the validation and application of the promise tool. And on the WeChat account, we have some articles that share the latest research, and also we have and to further communicate with all the scholars within the mainland China, we host the PNC China Work Symposium. Up to now, we have hosted for about 5 symposiums. The latest symposium is held this year in September. We also invited 4 core promise experts from PHO organization to tell us the latest developments of promise tools. Also, Professor Ren has a different academic roles. So to better promote the idea, we also host other academic nursing conferences to help us promote the promise concept. Here are some examples. And we also have some workstations across different provinces. For some offline and online lectures, we want to let more and more clinics, medical staff to know the idea of promise. And also we have published a book called The Theory and the Practice of Patient-Reported Outcome Measurement to let more and more scholars know that the outline of PRO and the practice of how promise is being used across the world. And we, for the second book we are working on is we want to show some research projects we are now working on, like measurement study case and information-based study case, to give more and more influence of this tool. And Professor Ren also wrote some passages in the pediatric oncology nursing textbooks to let the nursing students know how we can embed the promise into the pediatric oncology. So based on all these things, we have approved several research projects about promise in China recent years, and the amount can be up to 240 million Chinese yuan. And here are some examples of our research funds. So we are basically focused on how to give the psychometrical evaluation of these tools and how to use these tools in the clinical situations. And also we have done some translation work with the help of the PH work. So here are some examples of the promise tools. It can be listed as different symptoms, and each symptoms have different kinds of promise forms. It can be short forms or the full item bank based on your research purpose. So here are some examples of how we do the validation and application across the hospitals in mainland China. So we also have some pros in the clinical evaluation of traditional Chinese medicine with some famous scholars in China. So in all that in our group, we mainly focused on our research based on the cancer population, but promise is a wider tool, can be used in different patient populations and the general populations. So for us, it is a long way to go for promise to be used in more specific patient populations in China. And we also hope that we can build a cooperation between different countries to use this tool to have more deep researches on its clinical application. And here are some examples that papers that we have been published. So for future, we will continue to construct PNC China, and we hope that this workshop can let both us know that Promise is a worldwide tool that can be used to listen to the voice of patients, and we hope that we can have further collaborations. Thank you.
Thank you very much for this amazing presentation. If anyone has a question, please don't hesitate to drop it in the chat room. So, Prof. Shangrong, so we all know that Promise is used worldwide, as you said, and that is really very effective to hear the patient's voice, as you put it. However, I'm interested to know in China, because you are a specialist in cancer, and how wide have been it used outside cancer patient in China?
Yeah, that's a very good question. Our task is try to introduce this idea to more wide use. So we built the PNC China Net. So far, 87 hospitals signed contract together with us. They want to use this tool cross disease. So the cancer area is just a part of them. So far, since this tool was designed to use across disease, so the user are not limited in the cancer. So that's widely used in now, and especially in future. Yeah.
Thank you very much for your answer and for your presentation. Now we have with us our Dr. Sulaiman Al-Sabi'i. He is also interested in patient-reported outcome in Oman. So let's hear from him about the practice, environment, leadership, and collaboration. So there is a question from Dr. Sulaiman, who asked, did you explore if work environment is linked to Promise, Prof. Shangrong? So, Prof, we have a small question from Dr. Sulaiman.
Yeah, okay. Yeah, work environment. Yeah, that's also very important part to promote Promise. Yeah, we try to work it through research and also through some policy making. For example, in recent years, our government pay more attention to the patient's voice. So how to push, I mean, even mandated the physicians, I mean, the caregivers to spend time to listen to the voice. I think that's the work environment we should work together to build, to let the voice, play role even better in future. Yeah, that some place the environment is good, some place is not so good, but yeah, that's in future even we can work together to figure out a good model. Yeah.
Thank you very much, Prof. Yuan Shangrong, and I will leave the floor to Dean Sulaiman.
Thank you.
Thank you very much, Prof. Yuan. Maybe this is the next project that we can work together collaboratively to see how the work environment is linked to Promise, and and look that perspective from different cultures. I'm sure we will have a very nice findings to report and to build on. So is my presentation clear?
Yes, doctor, we can see it.
Thank you very much. So this presentation will be kind of a continuation to the presentation given by Prof. Wine and her students. Thank you very much. So it is about the patient-reported outcomes in Oman, practice environment, and collaboration. So I'm going to discuss briefly about the types of patient-reported outcomes, the sources of those outcomes in Oman, and what kind of factors can contribute to them, and then relate those outcomes to the practice environment and also to the interprofessional collaboration here in Oman. And then finally, I'm going to conclude with the future direction. So starting at the beginning, the ultimate goal of a clinical research is definitely to improve the life of people, including the patients, family members, healthcare providers, and the overall system functionings. So because of that, having measurable outcomes is of highest importance, because operational planning, strategic planning, so what kind of activities nurses do in the hospitals can be based on that kind of outcomes. Generally, the patient-reported outcomes can be classified under 5 categories: the health-related quality of life, functional status, symptoms and symptom burden, healthcare behaviors, and finally, the patient's perception of their healthcare. So the question came, what are then the sources of patient-reported outcomes in the Sultanate of Oman? Before going to that answer, let me give you kind of a very quick overview of healthcare system in Oman, so we'll have a better idea about the context and how it relates to the PROs. So total number of population is around 5,209,000. 56% of them, they are Omani, and 43% they are non-Omani. If we look at to the healthcare structure, the healthcare structure mainly is managed by the Ministry of Health, where we have 51 tertiary hospitals, 21 extended polyclinics, and then we have 191 health centers in the country. The healthcare workforce in Oman, we have total of 14,361 staff nurses. 48% of them, they are Omani. We have also 5,807 physicians. 70% of them, they are Omani. And the pharmacists, almost most of them, they are from Oman as well. Now look at into the measure how we look to in terms of staffing. If you look to this kind of interactive map, and if you click on this map, it will give you that kind of interactive view where you can see what is the number of nurses and midwives per 1,000 population in the country. So if we compare, for example, we can see that United States, as an example, they have 15 nurses per 1,000 population. In China, it's 3.3. We are somehow close, 3.4. And also in UAE, Saudi Arabia, we are almost close to that kind of a number. And the color over here give an indication. So this color, the dark one, that's mean the number of nurses is more than 6. So for each 1,000 population, there are 6 nurses to take care of. Now, coming to the question, what are the sources of patient-related outcomes in Oman? Mostly, it depends on the Ministry of Health, and through that website, we get information from the annual health report. And the other source is the equality offices available in each hospital. And then in case, for example, there are some kind of a national level research projects conducted where we reported data on the patient-reported outcomes. But this figure, it tells very clearly that we don't have kind of a national database where we can look at to the distribution of the patient-related outcomes, how they are comparable between the private and public sector, and what kind of strategies can be enhanced in the future based on the findings. So that area still is not well structured, but the main source is the Ministry of Health. Now, an example of the indicators that we read from the annual report from the ministry is, for example, the maternity mortality rate, the infant mortality rate, and so on. Now, the second part, we know those are the patient-reported outcomes. The question came, what kind of factors can influence or improve the patient experiences? So based on research, those factors, they can be related to the patient's clinical profile, individual level factors, or those factors can be modified in our system in order to improve the patient level or the patient, experience in the hospitals. So the research that I have conducted with my team was focusing mainly on the organizational level factors, where we give some kind of recommendations about the work environment and how the work environment can be improved in order to improve the patient experiences. So I'm going to discuss about the Oman large-scale national study. Here is my research team. We have, Dr. Omar Rawajfa from Jordan. We have Dr. Riado from United States. He was with us before. Prof. Raida from Jordan. We have Majid Al-Maqbali. He was the director of nursing in the Ministry of Health. And we have also Dr. Ikram. He is the senior consultant in oncology department in the, oncology center. So the study aims were to assess the nurses' perception of equality of a practice environment, assess patients' satisfaction with the quality of care, assess the interprofessional collaboration, explore the nurse-reported adverse patient events in Oman, examine the relationship between the work environment, collaboration, and how they are relating to the adverse patient events. Proportional stratified cluster sampling was taken, so nurses who are working in different hospitals across the 21 governmental areas were recruited. So we have in Oman here the governorates. It's kind of states. We have 11 governorates. From each governorate, we took at least one public hospital and one private hospital whenever available. So we end up recruiting nurses, physicians, and patients from 21 both government and also private hospitals. The number of doctors participated were 348, patients 1,700, and more than 2,000 nurses participated. The study instruments. The work environment was assessed using the practice environment scale of the Nurse Work Index. The collaboration was assessed using the assessment for collaborative environment assessment, and both of those were patient-perceived instrument about the environment. Patient-reported outcomes was assessed based on two instruments. The first one is the adverse patient event items, and these items, it tells nurses to reflect back on the last year to what extent the following incidents have occurred during the last year: patient and family complaints, verbal abuse, false nosocomial infection, and also medication errors. The second measurement of patient-reported outcome was patient satisfaction with the quality of care, and this was also investigated looking to three aspects, which are the satisfaction with overall quality of care during the hospitalization, satisfaction with the nursing care specifically, and then the last question was whether you are going to recommend the hospital for a friend or for a family member. So the results. In nurses, we have, 87% of them were females. On average, they spent 11 years in nursing. 58% of them were non-Omani. More than half had a diploma degree in nursing, and 41% of them, they were working in medical and surgical units. For patients, 59% of them were female. On average, they were 37 years old. On average, they stayed for around 13 days in the hospitals. 31% of them has secondary school, and 20% have bachelors, and 69% of them, they were admitted in governmental hospitals. The findings were as following. So when we assess the work environment, there are several areas. One of them is the foundation for quality of care. The second is the collegial nurse-patient relationship. Then nurse-manager ability, leadership, and support, the participation in hospital affairs, and the staffing adequacy. The highest reported element of work environment that we represent in the hospitals in Oman were the foundation for quality of care. And the least was staffing and resource adequacy. And I think this is, similar across several countries. And I guess maybe also there's kind of staffing issues around the Asian hospitals and also in China as well. If we look at the work environment by nationality, so the blue one indicates the Omani participants. The orange is the non-Omani. We can see non-Omani, they have better perception of work environment. And people who are working in private hospitals, they have somehow better perception of the work environment than people who are working in government and hospital. And that's understood because the complexity of care and the type of patients admitted to the governmental hospital, they are more severe and complicated compared with patients who are admitted in the private hospitals. In terms of collaboration, the findings showed a mean of 2.9 on a scale from 1 to 4. So that's mean they are above the midpoint, indicating kind of a moderate perception of collaborations. Now, look into the patient satisfaction with the quality of care. The composite score was a 3.8 out of 5. Again, it's kind of a moderate perception. Overall, they have a good perception of the quality of nursing care and of the hospital care in general. When we ask them to what extent you agree to recommend the hospital for a family or a friend, majority they were, in favor of recommending the hospital. So 43% strongly agree, 16 agree, and 27 is somewhat agree, or the way around. So majority, they agree that the care they provide in the hospital was effective and would like to recommend it for a friend. The adverse patient events. The most reported adverse patient events in Omani hospitals that were included in the studies were patient and family complaints, followed by the patient and family verbal abuse. And the least was the patient falls. And those findings were really interesting, and it highlights an important concern that need to be taken into considerations, because we thought at certain point of time that the major concern was the infection, or it was the medication errors. But in fact, the major is the patient and family complaints, and also the verbal abuse. Then we look at also to the relationship between the work environment and also adverse patient events. So the findings were supporting the hypothesis that as the perception of the work environment improved, the adverse events reduced. And similarly, as nurses working in a collaborative environment, the frequencies of adverse events reduced. We look at also as part of this project to whether the interprofessional collaboration can mediate the relationship between the environment and also the adverse events. So nurses who are working in a good environment, they have a good collaboration, which lead to having less number of patient adverse events. Part of these studies, we published 15 papers in Scopus Index. We presented 6 papers in conferences, and findings were now discussed at a higher level in the country, where people they are discussing about the future health vision and what are the factors. People mostly interested in what are the factors that impacted nursing burnout, specifically during the COVID-19 and post the COVID-19. So what are the future directions? I think there is a need to have a national database where we can reflect, we can learn, and we can implement and even plan for future improvement. There is a need also to measure the patient-related outcomes or reported outcomes more objectively, because currently most of the measures, they are depending on the self-perception, either from nurses' side or from patient sides. But I think we need to move toward the objective measures. And the most important part, which also I hope this meeting will be, the push toward that, is to have international research collaboration where we can look at to those aspects, the work environment elements, how those environment elements can impact the patient-reported outcomes across the nations and different cultures. Thank you very much. Thank you very much. This is the end of my presentation.
Thank you very much, Dr. Sulaiman, for your presentation. So I will leave the floor in the chat if you have any questions. So in the meantime, Dr. Sulaiman, I have a small question for you, if you don't mind.
Absolutely, yes.
You said that the ratio of nurses to 1,000 patients in Oman is approximately 3.3, right?
Right.
And it's similar to many countries in the world. And you've done your study and you've tested, or you've seen the nurses' satisfaction with the quality of care, the patient satisfaction with the quality of care, and the adverse events. So how do these results go with the Western world, in the sense if Oman were to increase the ratio of nurses to 1,000 patients like the Canadians and the Americans, how do you think this might affect your results in a way?
Thank you very much. This is really a very interesting question, Dr. Michael. So based on the findings, we have identified that the least satisfactory element of the work environment as perceived by nurses was the staffing and resources adequacy. And this was significantly correlated with the number and perception of the adverse patient events. So definitely, if we have more number of nurses, that's going to have a different perspective of the work environment. Now, currently, if we look at, for example, to the work of Linda Aiken, who's the mother of the staffing and the big advocate for the work environment, based on her work, she was a big advocate that there should be a specific range of nurses to be available in the medical floor, in the intensive care units, and also in the outpatient units. The state of California, for example, if we look at to that part of the question, the Western countries, they implemented this ratio where 4 to 5 nurses provide care, where 1 nurse provide care for 4 to 5 patients in the medical floor, and 1 to 2 nurses will provide care for 1 to 2 patients in ICU. And then they compare the patient satisfaction and the nurse satisfaction before the implementation of this policy and after the implementation, and they have definitely found that the perception of work environment have been improved, and the number of patient outcomes have been improved as well. The length of hospitalization was reduced, mortality rate was reduced, and even they link it to the readmission rate. And they have found that when people they are working in an environment with adequate staffing, the length of stay have been reduced, and also the readmission rate have been reduced. So again, we do have a shortages. And this shortages was doubled after the COVID-19 pandemic because of the turnover intention that we have in the country and across the world. But still, we are in a place where we are recruiting and retaining nurses to reach that level of satisfaction with the work environment and staffing.
Thank you very much for your answer. So your work is extremely important for policymakers, Dr. Sulaiman. Thank you very much. Please allow me to welcome Dr. Chen Yu from Fudan University School of Nursing. She will be presenting psychometric properties of self-reported measures of self-management for chronic heart failure patients, a systematic review. So the floor is yours, Dr. Yu.
Okay, so thank you. Hello, everyone. Let me share my screen. Okay, so is it clear?
It is perfectly clear, thank you.
Okay, thank you. So let me briefly introduce myself. I am Associate Professor from School of Nursing, Fudan University, and I also a core researcher of Fudan University Center of Evidence-Based Nursing and Shanghai Evidence-Based Nursing Center. So the main courses that I teach are medical nursing, health assessment, and nursing research. And my research areas are chronic disease management, older people nursing, and evidence-based nursing. So today I will share a systematic review regarding the psychometric properties of self-reported measures of self-management for chronic heart failure patients. Chronic heart failure is an important public health concern due to its high prevalence, high readmission rates, low quality of life, high healthcare costs, and increased premature deaths. But in China, there are 8.9 million people who suffer from chronic heart failure. So since it is a progressive disease, its management is very important. Self-management is one of the cornerstones for management for chronic heart failure patients. So it is recommended in many guidelines to reduce the risk of chronic heart failure hospitalization and mortality. So to date, there is no consensus on the meaning of self-management. It is often used interchangeably with self-care in some literature, so indicating a conceptual broadness. So while many researchers agree that self-management for chronic heart failure patients reflects the regularly performing behaviors within the context of daily living, such as a low sodium diet, active physical activity, self-monitoring of signs and symptoms, and medication adherence. So promoting patient self-management level is one of the main objectives of the management for chronic heart failure. Several patient-reported outcomes, that is, PROMs, of self-management for chronic heart failure have been developed and validated in different countries, among which European Heart Failure Self-Care Behavior Scale and Self-Care of Heart Failure Index are most commonly used. So as PROMs capture information that is not directly observable, so accurate and reliable PROM are prerequisites for obtaining robust results. So, however, there is no systematic reviews on the psychometric properties of PROMs. So we conducted a systematic review to identify and assess the psychometric properties of the PROMs of self-management for chronic heart failure patients. The following databases were searched from inception to June 1st, 2022. These are such as PubMed, Medline, EMBase, Senior, etc. Two websites, that is health measures and self-care measures, were also searched. The search terms were chronic heart failure, chronic cardiac failure, self-management, self-care, patient-reported outcome measure, scale, and the questionnaire. So these are the search structures for all the databases. The articles were included if these studies developed self-management or self-care, which was mentioned by authors, the PROMs for chronic heart failure, or validated at least one psychometric property of the PROM, and the language was Chinese or English. But the articles were excluded if a PROM was used to validate another instrument or as an outcome, and the full text, if the full text were not available. The cost-mean risk of bias checklist was used to assess the methodological quality of each study. So this checklist consisted of 10 domains and 38 items. That is content validity, internal structure, and remaining measurement properties. So each item is rated on a 4-point scale. That is very good, adequate, doubtful, or inadequate, using the worst score count principle. And the certainty of evidence was assessed according to the modified grade regarding 4 aspects. That is a risk of bias, inconsistency, imprecision, and indirectives. So this is a flow diagram of the literature search. So eventually there are 43 articles included in this review. Among these articles, 38 were in English, and all these articles were published from 2000 to 2021, and were conducted in 9 European countries, 9 Asian countries, and 2 American countries. So 11 PROMs were identified, such as SCHFI version 6.2, version 7.2, EHF, SCBS, EHF, SCBS 9 items, and other PROMs. So these are the methodological quality and the research ratings of some included studies. On the whole, the content validity, structural validity, and internal consistency were the parameters evaluated most frequently. The quality of content validity was doubtful or inadequate, while the quality of structural validity and internal consistency were very good. So according to the updated criteria for good measurement properties, the psychometric property was rated as sufficient, insufficient, or indeterminate. So 36 studies assessed structural validity, among which 8 were rated as sufficient. 41 studies rated internal consistency, among which 24 were rated as sufficient. Some reported other psychometric characteristics. 19 studies reported hypothesis testing for constructor validity, which were rated as sufficient. And 14 reported reliability, and 4 were rated as sufficient. 6 reported criteria validity, but all of them were rated as insufficient. And only 1 study reported responsiveness, which was rated as sufficient. No data regarding cross-cultural validity and measurement error were reported. So this table shows a certainty of evidence for each measurement property. So on the whole, SCH-FI version 6.2, version 7.2, and EHF-SCBS 9 were categorized as A. That means they could be recommended for use based on the methodological quality of each measurement property. Among the 8 language versions of SCH-FI version 6.2, 7 had high quality for structural validity and internal consistency due to multiple very good quality studies. Among the 3 language versions of SCH-FI version 7.2, all had high quality for structural validity and internal consistency and the hypothesis testing for constructural validity. And among the 10 language versions of EHF-SCBS 9, all had high quality for internal consistency, and 6 had high quality for structural validity. But the content validity of most versions of 11 prompts was low or very low. So whether the low quality is a methodological problem or a reporting limitation needs to be carefully considered. So in conclusion, based on the findings from the included studies, SCH-FI version 6.2, version 7.2, and EHF-SCBS 9 could be recommended to evaluate self-management for chronic heart failure patients. And the further studies are necessary to evaluate the other psychometric properties such as measurement error, cross-cultural validity, responsiveness, and criteria validity. And also there is a need to carefully evaluate the content validity. So these are some references. Okay, thank you.
Thank you very much, Dr. Chen Yu, for your presentation, for the systematic review. We have a question from Dr. Samia Al-Harrasi. She's asking, does the CHF self-care measure have a reflective impact on biological indicator? So whether the cardiac heart failure. Can you read it?
Yeah, I am reading this question. Oh, thank you so much. Do you mean the biological indicator? Do you mean some cardiac function or LVEF. It is the main of biological indicators. In my opinion, as these prompts of self-care, they do not reflect these biological indicators, as this is the patient, they reported how their feelings or how they do some regular self-care of their behaviors. So I think there are no biological indicators in these measurements. Cardiac functions, weight, or even activity, tolerance. Oh, these are some other questions which is not included in these measurements.
Okay, so
Yes.
so doctor, you showed strong evidence supporting the use of these tools for assessing the self-management in chronic heart failure patients. However, there are gaps, as you mentioned in your last slides, like the lack of cross-cultural validity, the measurement invariances. So my first question is, how do you see future research that can address these psychometric properties? And what do you think are the challenges that might arise when you apply these tools in other diverse patient population?
I think the translation of these measurements in different countries or different contexts are very different, because we need some rigor methodologies to do this progress. So I think maybe we need just like this kind of collaboration between different countries, and we do this collaboration to test or to find how can we find this cross-cultural research of instruments and what's their psychometric progress in different countries. Yeah.
Thank you very much for your answers and your presentation, Dr. Chen Yu. Now I will leave the floor to Dr. Judy Arulapan, who will present interprofessional simulation, insights, and outcomes. So the floor is yours, Dr. Judy.
Hope my screen is visible.
Now we can see your screen. If you want to put it in presentation mode.
Okay. Can you?
Yes, we can, Doctor. It's perfect. Thank you.
Thank you very much. Happy morning, everybody. I'm so happy to participate in this joint research workshop between the College of Nursing Sultan Qaboos University and School of Nursing Fudan University, China. And I'm Dr. Judy Arulapan. I'm a certified healthcare simulation educator, and I'm currently working as Director of Nursing Laboratory and Simulation Unit at the College of Nursing Sultan Qaboos University. The title of my presentation is Medical and Nursing Students' Experience and Challenges in an In-situ Interprofessional Simulation in a Middle Eastern Country, a Qualitative Study. I would like to thank my investigators, Dr. Ken Masters, Dr. Aisha, Dr. Amal, Dr. Amna, Dr. Ms. Aisha, Dr. Nasser, Dr. Iman Al-Hashmi, Dr. Gerald Amandu Matua, Mr. Abdullah, and Ms. Sakia. This is an interprofessional healthcare team who participated in this study. So, as we all know, simulation is a powerful tool that could be used to improve the individual and team performance while managing rare but serious patient events. So especially in-situ simulation is a practice in the clinical environment rather than doing it in the simulation lab using simulated scenarios, which enhances the learning and improve the patient care in the real clinical setting. So interprofessional simulation-based learning ultimately improves the interprofessional communication and teamwork. It enhances the patient safety. It increases the understanding of roles of other healthcare professionals. It enables to provide culturally competent holistic care, and it reduces the adverse events attributed due to misunderstanding and improper communication between interprofessional team members, and it enriches the understanding on the management of emergency and rare clinical situations in the hospital. So the objective of our study was to explore the experience and challenges faced by undergraduate medical and nursing students in an in-situ interprofessional simulation. We adopted a descriptive qualitative research and exploratory research design, and the study was conducted in the hospital, our hospital, Sultan Qaboos University Hospital, in the emergency medicine department, which is an in situ situation. And the participants were from the College of Medicine and Health Sciences and College of Nursing. So the population included senior clerkship students of College of Medicine and Health Sciences who were placed in emergency medicine rotation, and advanced clinical nursing students who were in the graduating semester from the College of Nursing, and the study was conducted in fall 22-23 semester. So we adopted a consecutive sampling technique because we had only 10 students registered in advanced clinical nursing course and 8 students in their emergency medicine clinical rotation. So the inclusion criteria was the study included all the students doing emergency medicine rotation and advanced clinical nursing. And the exclusion criteria, actually I kept the exclusion criteria as students who were absent on the day of simulation and the students who declined to give consent. However, nobody declined and everybody participated, so that none were excluded from the study. So coming to the description of IP simulation, because I wanted everybody to understand the flow of simulation so that it will be easy for us to understand the results. So the first, we did a need assessment. So the need assessment survey was conducted by the faculty of College of Medicine and College of Nursing to understand the theory practice gap between the courses. So we understood that palliative care is a rare clinical situation where the students had never encountered a palliative care situation in the real clinical setting. So we decided to have management of palliative care as a simulation scenario in our particular simulation. So we constructed measurable objectives considering the learning objectives of both College of Medicine and College of Nursing. And we developed a in situ standardized patient simulation where there was a terminally ill patient with cancer admitted to the emergency medical department, and the patient was seriously ill. This was a scenario we created. And we designed the scenario considering the learning objectives and outcomes, and the scenario was developed by the course coordinators and facilitators of both the courses. And the scenarios were properly reviewed by the clinical experts in emergency medicine, palliative care, and critical care nursing. So after that, we used real fidelity. Say, for example, conceptual fidelity. We took the real original data from the hospital and we blinded, we removed all the patient identifiers. And so that in order to give a true reality of a real scenario, we took a real case from the hospital. And the physical fidelity was established in terms of in situ simulation. Since the study was conducted in the hospital, the physical fidelity was maintained and psychological fidelity was maintained because the emotions were created in a way. The wife was crying and she was rolling and she was crying, and the students felt the realism in terms of psychological fidelity, and that was integrated in the simulation. And we maintained a facilitative approach where the simulation was conducted for 45 minutes. And the simulation was repeated for 4 times because we wanted to ensure that all the students, 18 students had to participate in the simulation. So we repeated the simulation 4 times, and we blinded the students because except the performers, others were not knowing about the scenario. So everybody was given an opportunity to perform their role as role performers. And before 1 week of the simulation, we provided the pre-briefing materials related to palliative care. But the scenario was not informed to the students. Only on the day of simulation, the scenario was open to the students. And we pilot tested, we ran a dry run of the scenario because we wanted to ensure that the simulation is running properly in the hospital. So we did the mock scenario piloting in the lab before it was actually implemented in the hospital. And then we did a pre-briefing for 15 minutes where both the College of Medicine and College of Nursing students were together during the pre-briefing. And also we oriented the students to the team steps, which is an evidence-based team performance framework. And the students understood how they have to work together as a team. And then we had a debriefing session where we followed a GAS model of debriefing, where the debriefing took for a long time. It was around 1 hour 30 minutes. The debriefing took place where both the discipline students participated together in the debriefing process, where the debriefing was done by the College of Medicine faculty for the medical students, and the debriefing was done by the College of Nursing faculty for the nursing students, where they were sitting together so that the students were able to understand each other's expectations and roles and expectations in the scenario. So even we did a debriefing with the standardized patient simulation participants and the students as well. And finally, we concluded the simulation with the evaluation, where the students evaluated themselves using a simulation effectiveness tool, and they evaluated the simulation using the National League for Nursing Instrument Simulation Design Scale, and the facilitators evaluated the learners using Creighton Competency Evaluation Instrument. So these were the real healthcare providers who participated in the palliative care simulation, where the nurses, the nursing students performed their role as primary and secondary nurse, and the medical students performed their role as senior consultant and resident. And in addition, we brought the real team of palliative care physician, emergency medicine physician, palliative care nurse, psychologist, and social worker from the hospital, where everybody, the real people, took part in the simulation. So coming to the data collection instruments, we collected data about the demographic variables of the undergraduate nursing students and the medical students. And in part 3, we had some questions related to the challenges and experiences of undergraduate medical and nursing students on interprofessional simulation. So we sought the ethical approval from the Research and Ethics Committee of College of Nursing and Medical Research and Ethics Committee of College of Medicine and Health Sciences Hospital in the Sultan Qaboos University Hospital. And we got Dean's Fund and permission from the deans of the colleges were obtained. And none of the identifying information were collected from the students. And we stored the data in the password protected file. And the participation was voluntary and no risk were involved in the study, since no direct physical and psychological injury also happened to the study participants. So the focus group discussion took place after the simulation. The focus group discussion took place by a qualitative researcher started the focus group discussion. And in the focus group discussion, 8 medical students and 4 female nursing students participated in the study. So the qualitative researcher asked the question, moderated the session, and recorded the session, and other researchers observed the process. So the data was analyzed with the initial transcription, and the text was corrected after that, and the transcription was reviewed for the accuracy, and verbatim was generated, and punctuation was inserted wherever it was appropriate. And we did the inductive thematic analysis, and thematic network was developed. And the thematic network was transported, and illustrative quotations were identified. So coming to the results, we found some interesting findings following this inductive thematic analysis. So especially the first challenge was related to IP communication and collaboration. So both the College of Medicine and College of Nursing students mentioned that they had challenges with the communication, because they were not knowing their role, because they were not aware of their roles and expectations, and they were not understanding their scope of practice. Because of that, they had challenges with the communication. So the medical students were talking to themselves, and the nursing students were talking among themselves, and they did not collaborate actually during the simulation. So that was a big challenge they experienced because of the lack of role clarity. The second issue was role clarity and expectations, because the students were not knowing their expectations and roles, what they are expected to perform in a particular clinical situation. And the third challenge they experienced was because of the lack of low clarity and miscommunication, they were not able to function as a team, and they were not able to make a decision. So this was a challenge we found in terms of IP communication and collaboration. Coming to the patient and family care, because this is a palliative care simulation, so the students experienced issues with the family involvement and support, because they were unable to support the family due to lack of role clarity. Medical students were confused whether they should be supporting the wife who was crying, and the nursing students were running behind the wife, and they were trying to console, and there was again lack of role clarity with the students. And they were also expressing that they could not manage the emotional situations due to sensitive emotional situation, because this is a patient was in a critically ill situation, and they were unable to handle the emotional situation. And also they mentioned that more practice is needed to provide patient-centered care as a holistic interprofessional healthcare team. And the other challenges they experienced, because they also had experienced stress and coping in the clinical setting, because the situation was an emergency situation, and they really had a lot of stress, and they could not cope with the clinical situation, which is palliative care. So similarly, palliative care and sensitive cases, they mentioned this is the first time they were exposed to such a sensitive case, that was a big challenge for them to deal with. And also they mentioned they had issues with the professional identity and growth, because since they were not aware of their roles and limitations, they could not seek for help, because though there were palliative care physician, emergency medicine physician, everybody was around. Since they were not knowing whom to contact, they did not contact the persons appropriately. So they mentioned since they did not understand the professional roles, they could not contact the concerned people for help. Similarly, they had issues with social interaction among the professions. They mentioned they never talked to nursing students, or the nursing students mentioned they never spoke to medical students in their clinical practice. They have never interacted with each other. This was really surprising for us because lack of social interaction, and that is a big challenge. That is the reason they were not able to mingle with each other during the simulation. Similarly, they said they learned how to deal with different people since they were exposed to interprofessional simulation. And they recommended some future improvements and recommendations, like they wanted us to initiate simulation-based learning and practical experience from the beginning courses to advanced courses. It is not only at the advanced course, we should be starting simulation with rare and uncommon clinical situation. They also said it should be started from the beginning so that they will learn how to collaborate with the interprofessional healthcare team members. And also they suggested to organize special classes and courses on interprofessional education. Also, they suggested for course restructuring. Say, for example, they suggested starting from admission to end of starting from admission until the transition of care. The simulation should be organized in a way the patient is getting admitted to the hospital. Until the transition of care, the simulation should be planned so that the students will be able to start their care from the time of admission until the discharge and the transition. This is the suggestion the students gave at the end of the simulation. Coming to the discussion, actually considering the benefits of interprofessional care, many healthcare settings have started adopting team-based care as well as interprofessional education. However, many literature, I could say, I have cited only very few literature here. However, there are many literature which says that improper communication between the IP team of healthcare providers causes many medical errors. So therefore, IP education and collaborative practice is highly essential. And lack of professional identity and poor communication is leading to, these are the main barriers for IP collaboration among the physicians, nurses, pharmacists, and mental health care providers. And also many researchers have pronounced that unequal role of because the participants do not know their roles. That is the reason they are unable to collaborate with each other, and they have a fear that, oh, if I do this, I will be judged by other team members. That is the reason they are not collaborating with other healthcare team members. So therefore, we should be giving proper roles, and we should be providing more time and training for these healthcare providers to collaborate effectively. And limited time for patient-centered care and negligence of patients' context and social determinants of health is another challenge, which is expressed in many literatures. And in the literature, it says palliative care and IP simulation improves the IP competency scores among medical and nursing students. And furthermore, simulation-based learning in palliative care enhance the understanding of importance in interdisciplinary and interpersonal skills, teamwork, confidence, and preparedness in one's ability to communicate during the emotional challenges, and it positively influences the IP teams in the clinical practice. Finally, the students' attitude towards interprofessional learning is improving through this interprofessional collaborative simulation. So there are various challenges, it is adding to many benefits in terms of interprofessional education and interprofessional collaboration. So these are the various literatures really which is supporting our study findings, which is giving us a direction that we have to really go for interprofessional simulation as well as interprofessional collaborative practice in the real clinical setting. To conclude my presentation, I would like to say interprofessional simulation-based training is a useful tool for both medical and nursing students to enhance their collaboration and communication skills. And interprofessional simulation provides an opportunity to learn and understand about each other's strengths and limitations. And team-based care minimizes the errors and enhances the patient safety. And finally, interprofessional education and collaboration is suggested from the beginning level courses to the in the healthcare education and training. So I had the limitation of finding some literature because specifically related to challenges, experiences, I had very limited literature, and the study limits its generalizability only to the study setting. And the future direction is I am planning to submit the recommendation to the Dean of College of Nursing and College of Medicine to initiate interprofessional education. Similarly, I have the plan of writing a recommendation to the hospital, especially the medical nursing director of SQH, to initiate interprofessional collaboration. In the College of Nursing, I am proposing to initiate interprofessional collaborative practice simulation clinic, which will be established in the near future. And we have the plan of establishment of interprofessional collaborative clinic in the hospital, where all the healthcare practitioners can work together as a team, and they can learn from and they can practice in the real clinical setting. With this, I would like to conclude my presentation and thank you for your patient listening.
Thank you very much, Dr. Judy, for your insightful presentation. So please, if you have any question for Dr. Judy, go ahead and drop it in the chat box so we can I can share it with her. Dr. Judy, it is a very nice, in fact, study. Thank you very much for that. And we all know the importance of simulation, and you've done an in situ simulation, including interprofessional collaboration, which is really amazing. Now, we all know the advancement of the virtual reality technology, and there is a growing discussion about the VR potentially replacing in situ simulation. Do you believe that VR can really provide similar benefits to in situ simulation and can be included in interprofessional collaboration, and or really are the aspects that make in situ simulation are irreplaceable?
In my opinion, actually, I always go for in situ simulation because it is a real practice which is happening in the real setting. However, for virtual simulation, it can be used for the practice. There is no harm in it. We can still, because even I tried utilizing VR simulation in my practice where we can really have some complex scenarios where the students can try and they can learn how they can collaborate and they can solve the clinical problem. But the real clinical practice, what happens is the students are able to really communicate and collaborate with each other. So when there is a real person around, say for example, in our simulation, we invited the real participants into the simulation. For example, there is a question from China, who is the SP? That is a standardized patient. Because we invited a standardized patient who is a professional actor, we trained the standardized patient. The wife was also a standardized patient and the patient himself is a standardized patient. We trained both of them how to act in the scenario. They performed the role as a real patient and the real wife. Because the emotional realism we brought, because the wife was crying when the patient was struggling with the pain and he was struggling really. So the wife acted in a way that she created an emotional realism. Students also, even we felt like crying in that situation. That kind of emotional realism we brought in the simulation, and it was so exciting. So I would recommend we will always go for in situ simulation. Then virtual reality is an additional option where the students can still practice. So that is my personal opinion about this VR and in situ, with my experience in both.
Yeah. Thank you very much, Dr. Judy. This is very interesting. And thank you, Dr. Chen Yu, for your question. So let us move to our next speaker from Fudan University, joining us, Dr. Wang Ani. Dr. Ani will present an online 5-week professional identity program for nursing students during the first wave of COVID-19, a 2-arm randomized trial. So the floor is yours, Dr. Ani Wang.
Thank you for your introduction, Dean. I would like to briefly introduce myself. I am an associate professor in School of Nursing at Fudan University. Actually, my background is psychology, and my research area is trauma, stress, and resilience. During the first wave of COVID-19 pandemic, I was also assuming as a student coordinator in the School of Nursing Fudan University. So that's the reason why I did this intervention for the nursing students. Okay, so here I would like to briefly introduce why we conducted this program, because the nursing students who are in the clinic rotation are facing multiple stresses like caused by COVID-19 pandemic and clinic rotation. They are with heavy study stress, and also in their last year, they were facing with job funding stress. So those multiple stresses had caused the psychosocial stress among the students. So as the student coordinator, our primary responsibility is to care about the psychosocial general well-being of the students. So I collaborated with another student coordinator, Wu Ming, and we developed this program. Okay, so here comes the question: how we can make this program successfully or effectively reduce the stress among the students? So we should need to find a suitable, appropriate theory to guide us to develop the program. So we use the professional career self-efficacy theory to guide us to develop the program. As you can see from this picture, shows the process that how a nursing student develop their professional identity. First, they entered into the nurse profession, and the nurse profession will produce social comparisons with other professions. And then in this, following this process, we can see that the students' direct experience, their substituted experience, and the social persuasion from their family member or friends, and also accompanied with their physio-psychological condition. This process can greatly influence the internalization of this profession, and then finally produce positive or negative distinctiveness from nurse profession with another careers. So focuses on this core process, we developed a 5-week professional identity program, and then we do the randomized RCT in randomized controlled trial to see whether it is effective or not. So here the program lasted for 5 weeks, and each week we have different topic in each week. As you can see, there are 5 topics, including group building, role modeling, easy coping, mental reflecting, growth doing. So in the first week, it was about group building. Then we have set the specific activities in each week. In the first week, we introduced the group rules to the participants in our intervention group, and we asked the students to share their current COVID-19 experience during the clinical rotation. And lastly, we introduce a stress monitoring to them, and invited them to do the practice every day or every night before bed. And in the second week, it was about role modeling, which means that we invited our frontline COVID-19 nurses to share the vivid experience when they're doing the COVID-19 pandemic. And after the lecture, we asked each student to do the interactive interview within the group. And lastly, we asked them to do to draw a picture of their self-portrait, like to discover their advantage and disadvantage of themselves. And as a time limit, I think I cannot introduce each activity one by one. So after those programs was developed, we sent it for a panel of feedback from a panel of experts major in nursing, psychology, and social work. And after that, we further revised this program. And then we recruited 115 students in our school, and we randomly allocated into intervention group or control group at the hospital level to control the contamination within a hospital. And we do the pre and post evaluation. And so during the program, we hold a Zoom meeting weekly, similar like this, and we group all the participants in the intervention group by their hospital, and most importantly, we set some group rules, such as we invite a student facilitator to help us to check the attendance of each participant, and also help us to check the homework whether they have finished or not. And after the intervention, we have give a small gift to all the participants in this study with like few dollars. And here is the recordings of each room online meeting, and this is the stress relaxation training that I have given to the participants. And those are the platforms that I used to let the students to post their homeworks. And in this platform, the students can could see the homeworks from themselves and as well as from the other participants. Okay, here I would like to show you one of the homework they do. This is a portrait that I asked them to draw about their advantage and disadvantage. As you can see in this picture, it is a boy, and the boy said he is adaptive and he is full of encouraging, and so he said in the future maybe he would prefer to work in emergency department or surgery department. So this homework is mainly to let them to discover their advantage and disadvantage. And this is the last homework that they have to do. This also drawing a picture about the growth plan in the future. And combined with the previous homework, I asked them to list their long-term and short-term goals and how they could combine their advantage and disadvantage to achieve those long-term or short-term goals. And after they posted their homework, I also invite everyone to further describe what they have drawn and ask the other students to give the comments and give the mutual support. And here we go. Here we can see whether the program is effective or not. We use the two scales to evaluate the outcome. One is professional identity scale, and the other one is professional self-efficacy scale. As you can see, not all dimensions, but some part of it got significantly improved, including professional identity, professional self-image, self-comparison, and self-reflection, independence of career choice, capacity of information and collection and playing. So as you can see that those dimensions got significantly improved after the intervention in the intervention group compared with the control group. Okay, and also we got we also collected some qualitative feedbacks from the students, and the first is about the overall appraisal of the intervention, and we have randomly invited 12 students in the intervention groups to do this, and they all gave positive appraisal of the intervention, and they have claimed that have gained overall growth after the intervention. And this intervention has also helped them to know more about themselves, like advantages and disadvantages. And also, this intervention also gave them a deeper sense of belonging, especially during this COVID-19 pandemic, with a lot of, especially when they are experiencing a lot of social isolation during the pandemic. And the second theme is about the intervention. And the students said that the topics are highly related to the professional identity. And they also admit that their pre-intervention professional identity is a key played a key role that influenced them whether they would be deeply involved in this intervention. And they also pointed out that the intervener was critical because as a student coordinator, I have already built a mutual trust between myself and the students. So this is a fundamental for successfully deliver an intervention. And the third theme is about the recommendation in the future. They recommended to combining offline and online activities because during the first wave COVID-19 pandemic, all the activities were conducted online. But in the future, they think that part of the activities can be held offline, especially for when we do some mutual sharing. And also, they pointed out that the group rules are vital in ensuring the fidelity of the intervention to ensure everyone participate in each activity. And also, they point out in the future, if other student or coordinator would like to deliver this program or intervention, the trust between students and interveners should be taken seriously in consideration. And this, luckily, and this program has already got published in the Nurse Education in Practice. I think if the fellows from Southern Campus University who are interested in this area, you can download the paper and get some further and detailed information of this program. Okay, so today this is a short sharing of my study. Thank you.
Thank you very much, Dr. Wang, for your very nice presentation. I really love this program, and I feel it is very efficient, in fact, for the mental health of our students. Now, I just quickly scanned the abstract of your paper, and I saw that the program did not show a significant reduction in stress level. Is this right?
Yes.
So what do you think? What are additional interventions that you can do, or how can you modify your program so to better address the stress management in the future?
Yeah, this is a very good question that we have also give some detailed discussion in the discussion part of this paper. I think there are two reasons why the stress was not significantly improved. The first one is that the content of our intervention, because the majority of activities in this intervention focuses on professional identity, not purely stress. So if your primary outcome is stress, then we will put more components in this intervention related to stress. Mm-hmm. And the second is that the stress relaxation practice, whether I did not count exactly the time, how many times they practice. So maybe in the future, if you want to do something to reduce the stress, you must do some fidelity, take some measures to ensure the fidelity, especially regarding to the homework practice.
Oh yeah, I understand these two arguments. They are very valid. You are absolutely right. Well, I have one more question because I love the topic about professional identity, and I believe that it has a crucial role in career retention. Do you think that your program can be used, for example, in the workforce, in the hospitals, in order to retain nurses? Because now the world is suffering from a global shortage. And do you think can it be adapted to the workforce?
I think it has the potential to be transferred to the nurses, not nursing students, because as you can see from all the contents, it is not restricted to be used in nursing students, and I think it's applicable to nurses as well. But I think it's maybe more applicable to the new nurses, not senior nurses. As you can see in one of my activity, I invited senior nurses to share their career development. I think it's more applicable to new nurses.
Great, thank you.
And also, as I know, I'm not sure, but I'm not quite sure, but I know that the intention to leave is much higher in new nurses.
Definitely,
right?
Definitely, yeah, the dropout is higher, absolutely. So yeah, thank you very much, Dr. Wang, for your presentation. Now the final presentation today is from Mrs. Francie Francis from the College of Nursing at SQU. Mrs. Francie will present time management, procrastination, performance, and anxiety among nursing students. So thank you. I will leave the floor to you, Ms. Francie.
Good afternoon, and thank you, Dr. Michael. May I know if my slide is visible now?
Your slide is, yes, visible. If you want
and I can make it in the full screen mode, yeah.
The full screen, and we can hear you very well.
Okay. Thank you so much for this opportunity, and good afternoon to everyone who is listening to me. I would like to present our study, which was on time management skills, academic procrastination, Test Anxiety and Academic Performance Among Nursing Students in Oman. It's a descriptive correlational study. And I'm Ms. Rinsi from the Maternal and Child Health Department of College of Nursing, Sultan Qaboos University. This was my wonderful team who was always hand in hand working with me to help me complete the study. It's Ms. Sheba and Ms. Cherry from the College of Nursing, Ms. Dulce from School of Nursing, University of Nizwa, and Ms. Habiba from College of Oman College of Health Sciences. These were our settings as well.
Ms. Princy, I'm sorry if I cut
Yes.
you. We cannot see the slides.
Is it the slides are moving from my side, Dr. Michael?
They are not. Maybe if you return to...
I stop sharing and share again?
Yes, please.
Okay. What about now, Dr. Michael? No, I think it just comes as a background. Choose this. That was the option that we had.
I guess if you can just share without going into presentation mode, it might work. Okay, now it works perfectly. Great.
You are able to see now?
Yes, perfect.
So this was our team. And please let me know when I move to the next slide if it's working.
Yes, it's working.
Okay. So looking at this picture, it just helped me reflect. All of us have come across this phase. When we are assigned with a task, we feel that we have a lot of time with us, but actually when we get to do it, we end up saying that we do not have time. So as professionals, if this is what we are going through, what more is our nursing students juggling with multiple tasks going through? So this was our area of interest, and we felt maybe poor time management will often end up in procrastination, anxiety, and might affect performance. This one also I was able to relate, and a tomorrow never comes when we want to push our task to unless we have a pressing deadline. So procrastination is a purposive postponement of an assigned task. We are presenting a part of our objective, which is to correlate between the time management and academic procrastination, test anxiety, and academic performance. What led us to this research? Being a teacher for the past 10 years, I often come to hear these comments where students say that, Miss, we do not have enough time. Can I submit this later? 1 week is not enough for the preparation, or I feel so stressed and anxious, so I didn't do well. This has been the common comments that we listen from students, and this was why we decided to really do this study and know what exactly is the situation. What literature has got to say? I have pulled up some statements from the recent literature that's been published regarding impact of procrastination on test anxiety, and there is a correlation, negative correlation between time management skills and academic procrastination, and a positive correlation with academic performance. So these studies are available as literature to support our finding. The research methods used for the sample size, we had around 560 participants who were recruited. Convenient sampling technique was used. Most of them were all of them were undergraduate nursing students. We had 3 settings: the Sultan Qaboos University, University of Nizwa, and the Oman College of Health Sciences. The research design we used was descriptive correlational design. Inclusion criteria: those students who have completed minimum their first semester in nursing college, who are full-time and who are registered in different nursing programs. And we involved students who are in diploma, baccalaureate, and the bridging program, where students who have completed diploma come to a baccalaureate. The research questionnaires that were used are, we used standardized questionnaires, time management questionnaires, questionnaire which was having a 35 item, and it had subscales which looked at time planning, time attitude, and time wasters. We chose this questionnaire because we also wanted to look at students' time planning attitude and their attitude and time wasting behaviors. Academic procrastination scale, the short version, and the test anxiety inventory was chosen. Our demographic data, we found that majority of the students who participated were females between the age range of 20 to 24 years. They were single and residing in urban areas, most of them taking a BSN degree program, and patient representation from the participating setting was equally represented. Academic data we secured was the cohort from which they were. Most of them were from 2019 cohort, year of study. 18 to 20% was the distribution between the years of studies. Majority were between the GPA. In the previous semester, their GPA was between 3 to 3.49. And most of the semesters, they rated that it was between 3 to 3.49, their GPA. And if there was at risk for probation, we reported only 12% were at risk for probation, and only a 10% reported that they were being in probation. Coming to our major findings, overall, we found that time management skills, the students had a fair level of time management skills. And when we looked into the subscales, they also employed the time planning activities and had good attitude towards time, and sometimes also reported engaging in time wasting activities. Regarding academic procrastination, they also had procrastinated behaviors in academic related activities, and likely to experience test anxiety. Our correlational study findings were, we noted a positive correlation with their time management skills and their time planning. And similarly, with time planning, those who had a good time planning had good time attitude. And we saw a negative correlation. Those who had poor time planning were those who had increased time wasting activities. And the time attitude also decreased if they were engaged in more of time wasting activities. The time wasting, there was a positive correlation that existed between time wasters and academic procrastination, time wasting and test anxiety, and a positive correlation existed between academic procrastination as well as test anxiety. In terms of academic performance, a positive correlation exists between the time management skills and their immediate previous cumulative GPA. The bivariate analysis showed a significant relationship between the students' time management skills and their gender, age, marital status, school, and the current year of study. So we felt it's important to now take into consideration that our students do face issues with time management, which has impact on other aspects of during their academic performances, like the procrastinating behavior and increasing the anxiety. So we feel the students need to be identified with such issues, and a support should be provided in the form of they should be oriented to what are the different methods that's available, so that they can utilize it in their daily schedules to manage time. And it can be through workshops, or we can have advisors identify their advisees and have a one-to-one basis of help that can be given to students in choosing an appropriate method of time management to put into practice. And sometimes support and counseling can be given to them if we find serious time management issues and if it affects their academic performance. Concluding that enhancing the time management skills, it is a skill that is not only required during the study period, but often required throughout, as long as we enter into a profession and work as a professional. We need time management and we need to work on the procrastination behaviors right from the student period, which will be a good asset for them in their future placement. Thank you.
Thank you very much, Mrs. Princey, for your presentation. We appreciate your help for students. If anyone has a question for Mrs. Princey, please don't hesitate to drop it in the chat. So, Mrs. Princey, you said that you carried out a bivariate analysis to see the correlation between the time management and the demographics, if I'm not mistaken. You talked about gender, age, and something else. I wasn't able to pick it up. So what does it mean in terms of gender? Let's say males or females, they procrastinate more, or do you have answers for that?
Actually, Dr. Michael, we are in the progress of doing a regression analysis to establish and justify if it is right. But as of now, the bivariate showed that the males have better time management skills. And so we want to go for a regression analysis to justify and bring out the right exact variable.
That's very interesting. And are you thinking of maybe doing this same study with other than nursing students to see if the nursing students have a particular time management which is different from students from other programs?
That would be an interesting project as well, Dr. Michael, to compare with other disciplines and to really see if there is something, there is better time management for us or not. we will think about it to extend the study.
Thank you very much, Mrs. Frincy. So if anyone has any question for any of our speakers today, we can either drop it in the chat, or we can start the collaboration sending each other's emails in order to but Ms. Frincy, in reality, in our school, girls are better at time management. There's someone's asking. Yeah, this is a very, I guess, interesting aspect, that we have men here at the College of Nursing have better time management. Do you have any answer to this, Ms. Frincy?
And means it is based on the surveys that we did and the results that came out, the way they answered the questionnaire, the difference between the girls are better or the boys. I have to support it with proper evidence and only tell about this. But there are various reasons. If not to talk about time management from the aspect of only working, I might say women always have multitasking, too many things to juggle and handle, while men can do one-to-one task better.
Yeah.
So maybe that is a reason as well.
Also, we have limited, I guess, the boys here are minority. I'm not
Yes,
sure.
minority. The number is different. If you look at my demographic data, you will see that 84% of them who answered the questionnaire was female.
Definitely.
So that might have also, but among that few, that's why I didn't want to really justify that it's a male, but we have to wait for our regression analysis to be done.
Definitely. And also maybe a comparison between the College of Nursing at SQU and the
other institutions,
to see if really also over there male students have better management. This could be also nice.
Nice, yes.
So thank you all to all the speakers for their insightful presentations. Really, this seminar has provided us with a rich platform for dialogue, for exchange, strengthening the ties between the College of Nursing at SQU and the School of Nursing at Fudan University. So we hope that today's discussion inspire further collaboration in the future. So let's really continue working together to advance research and improve healthcare practices globally. So thank you very much for my colleagues at SQU and for our colleagues at Fudan University for this wonderful seminar. Prof. Huyan, do you have anything to conclude with?
No, I'm really enjoying the presentation this afternoon or this morning in your site. I think I can see your research are quite in-depth and cover a lot of area of our nursing focused one. So that's really wonderful. I do hope that we could develop further collaboration in the future and can have some like in-person contact, not just online. So we can have some more eye-to-eye contacts. Okay. Yeah. Thank you very much. Thank you everybody for your wonderful presentation. And also the interactions are really very wonderful. And our moderator, you are a really wonderful moderator to chair this session. Thank you so much.
Thank you very much for your kind words, Prof. Yan. And I'm sure that we will have future collaborations, because I can see a lot of similarities, and while people were presenting, I can really things popping in my mind that we can collaborate on so many levels. So of course, we will start this wonderful collaboration, and hopefully we will publish a lot of papers together, and we will really advance our two esteemed universities together.
Yeah, thank you.
Thank you very much, everyone. And have a nice day. Have a nice evening.
Thank you, and have a nice day. Thank you.
Thank you very much. Bye-bye.